we have 5 speakers, and as you know, like because of some visa related issues, some delegates can't actually make it. So we have 2 pre-recorded recordings, and maybe we play the. So the first one is supposed to be Qinghua He from China, and maybe we can play the pre-recording first. So today we're going to talk about a lot of the AI applications across all ophthalmic specialties. I'm going to keep it very chill and interactive. So I see like quite a few, the familiar faces here. That we have, the local, the Indian delegates here. Please feel free to ask as many questions as you want, and we will try our best to actually answer them all. So without further ado, can we play the first recording, please? Thank you. Hey, Travis. Hey, how are you doing, man? Good. Hey, nice. Oh, good to see you. I hope the flight in is okay.
Yeah, it's okay. Going well.
Can we play the first recording? Do you guys have them? Yeah, okay.
Where did you find it from?
I can already see it on the podium, but it's not showing on the screen, but it's on the laptop already. Ah, good. Okay. Can we play it, please? Thanks. And we need to switch on the volume as well. There's no sound. Maybe stop first. Yeah, because clearly he's speaking, but there's no sound coming out. Let's play from the start. Yeah.
Good morning, dear audience. Thank you so much for having me here. I'm so sorry I cannot attend the conference in person due to the visa issue, but I'm still very glad to introduce you our recent work. My name is Qinghua He, and I'm currently a research assistant professor at CHK DOVS, working with Professor Ken Tan and Dr. Carrie Zhang in the ocular imaging and AI. Today, I would like to talk about our recent progress on computational imaging for enhanced AI in ophthalmology. And the specific project is to predict visual field loss in glaucoma patients from fundus photographs using spectral-informed AI. Visual field test is a golden standard for glaucoma diagnosis and management. It was conducted by a standard automated perimetry. In clinical practice, a newly diagnosed glaucoma patient should undergo VF test follow-up 3 times in the first year after initial diagnosis, and at least 2 times repeatable VF test should be done for each follow-up. However, the whole test procedure is time-consuming and highly dependent on the understanding and the concentration of patients, and the result is also dependent on the good instructions from experienced operators and the learning factor of test procedure. Therefore, it's impractical to do frequent VF follow-ups for glaucoma patients. Many studies have reported that OCT has the potential to predict VF loss from INFL thickness. While OCT is easier to use and test, it's still not cost-efficient and accessible enough for frequent follow-ups. Some other studies also indicated that red-free FP shows a significant correlation with OCT in identifying the RNFL defects. Since color FAP is more widely used nowadays, it is worthy to explore if it is possible to produce a pseudo-red-free FP from CFP to enhance VF loss prediction. So we have two specific aims in this study. The aim one is to develop a deep learning model for predicting VF loss parameters from CFP, and aim two is to evaluate if pseudo-red-free FP produced from CFP can improve prediction performance. To test these two aims, we need to figure out what is the current limitation of CFP. So CFP take RGB photos of fundus tissue to show the spectral information. However, due to the lower tissue absorbance and scattering at longer wavelengths, the CFP perform quite high reddish background, which can cover the subtle signal from structural details like small blood vessels. Using green or blue channels can filter most red light, but it will cause the loss of information in other wavelength range. Besides, it's quite challenging to pre-process CFP because of very limited spectral channels, high channel sensitivity of labs, and low spectral resolution. In this case, the spectral enhancement of CFP is needed to minimize the impact of reddish background and highlight the structural details of fundus tissue. For this purpose, we propose a computational multispectral imaging method to improve the spectral resolution of RGB cameras. Basically, this method requires a camera calibration step to derive a transformation matrix to transform the RGB response into multispectral images with improved spectral resolution. In the very early exploration, we actually need a multispectral camera in the calibration, while in the later optimization study, this step has been greatly simplified. For now, we just need to take a RGB camera to image a standard color chart with no reflectance, then everything is settled. We can acquire the multispectral images now. This method has many credits, like it requires no internal modifications and hardware attachments, and the metrics can be applied on retrospective data. More importantly, this method is applicable to all different types of RGB cameras, including the fundus camera. So we use the standard color chart to calibrate our color fundus camera and to develop the spectral enhancement algorithms and deep learning model. We collect 2,600 retrospective CFP images paired with SAP results. And then the semi was applied on CFP images to produce the pseudo-red-free FP as an input. And we use the efficient net V2 as backbone to train our deep learning model to predict VFI, MD, and PSD. And here is a workflow of CMI and deep learning model. And this page shows the example results of CMI. We can see that the CFP has been transformed into multispectral images from 450 to 680 nanometers. And after obtaining all the multispectral images, we selected 3 typical channels to simulate the RGB channels and remove their reflectance baseline to produce pseudo-red-free FP. And the examples, the results are shown at the right side. We can see that the reddish background has been removed from CFP while the structural details has been highlighted. So we trained the deep learning with using both using a CFP and pseudo-red-free FP respectively. And here shows the performance of the CMI and the deep learning models. Basically, EfficientNet V2-based model trained from pseudo-red-free FP shows the lowest MAE and highest correlation to real VFI, MD, and PSD values, while the enhancement provided by CMI over CFP is generalizable on deep learning models with different backbones and in different tasks. In summary, in our study, CMI accurately reconstructed the multispectral fundus images from CFP, and the deep learning model trained with CMI-based pseudo-red-free FP achieved the better performance in VF loss prediction. And the enhancement is generalizable other deep learning models and tasks. The limitation of this study mainly exists in the sample size and the relatively subjective design of the spectral enhancement algorithms. In the future, we will test our method on more samples, develop diverse spectral enhancement algorithms, and optimize our model to realize better prediction performance. So that's pretty much all about my sharing today. I would like to thank the support from my mentor, Professor Kaiman Tan and Dr. Karen Zhang, and all my lovely colleagues. Thank the conference team for inviting me to give this talk, and thank you all the audience for your listening. Please feel free to email me if you have any questions. Thank you very much.
Yep, thanks. We will proceed on to the next speaker, Marcus Ang from Singapore. We're gonna keep the questions to the end so that we can actually get the discussion, going in a very free flow and uninterrupted manner. So maybe we'll get Marcus to to speak next, and we're gonna end all the speaker session, and then we can start with the Q&A. Yeah. Can we have Professor Marcus Ang's presentations up, please? Thanks.
You want me to do it? I can do it. Okay. Morning. Thanks, Dan. Thanks for this invite, and very good morning to everyone here. I presume everyone here is slightly interested in AI, and as most of you would know, AI is part of our lives, and definitely going to impact our practice as well. So I'm going to focus about a particular topic, which is myopia, and I think to all of us in the Asia Pacific, we all understand the importance of myopia as a growing concern, and I think we have some exciting developments for AI and myopia, and I'd like to share some of the work that's being done. These are my financial disclosures. None of them are relevant to my talk today. So myopia is something that's close to my heart. I have two young boys, 5 and 9, and they are at risk of developing myopia. And in East Asia, as you know, my wife and I, both ophthalmologists, we harp on them and try our best to prevent myopia. But unfortunately, no matter what we do, myopia is going to affect not just children across East Asia, but also we're seeing growing trends outside of Asia as well. This is a survey, a summary survey of the different continents that we expect myopia to boom. And as you can see, after Asia, actually North America and Europe are closely second. So I think this is something that we should all be aware of. Now, myopia in itself, as you know, it's a refractive error. So it's not actually per se a disease, but when uncorrected, it impacts visual function. And so the WHO and of course IPB have recognized that myopia as an uncorrected refractive error impacts millions of people, especially around developing Asia. It has impact on education and thus productivity, and studies have shown that the impact goes beyond just visual function. There are also reductions in opportunities for many populations and societies. But I think what we're also concerned about is that as myopia progresses into high myopia, then into adulthood, then a lot of these individuals have a higher risk of sight-threatening complications, such as retinal detachment, myopic macular degeneration, as well as optic neuropathy, all of which are irreversible. So when the child develops myopia, progresses to high myopia, becomes an adult, then suddenly these complications can set in. So at the International Myopia Summit, which is co-chaired by myself and individuals from IPB and WHO, we have now advocated for a change in the strategy. So of course, myopia prevention has to continue, and we have to prevent myopia from getting worse in children. But really what we want to try and do is to reduce the number of individuals with high myopia. Because there is a lot of counter-argument about whether low myopia needs to be prevented at all. And so I think focusing our efforts into this effort is probably going to be more effective in the long term. So I'm going to show you a potential digital solution to myopia, right? And of course, in all of our countries, in all of our hospitals, we do have differing infrastructures, but this is a potential framework. And I'm going to show you how for myopia care, we can try and use both AI as well as infrastructure to try and fill up that ecosystem, okay? And we have successfully done this in the Myopia Center in Singapore National Eye Center. So for AI, right, as you can see, sorry, back to this slide again, AI is just one component of the entire ecosystem and solution. So today's talk is going to focus on AI, but I'll talk about a little bit about how you can, how it's important to understand this framework for you to implement it. So AI in itself is just a tool. It can be a research tool, it can be a commercial tool, but it's not going to work on its own unless you have the ecosystem. So I'll talk about AI first, and then we'll talk about the ecosystem. So if you look at all the AI for myopia specifically, there actually is quite a few research publications looking at using machine learning to, in the early days, to look at myopia progression and axial length elongation. And then in the later years, deep learning coming in. And of course, now AI methods are a lot more sophisticated than this. But of course, it takes time to train and to validate these AI. So these are the publications that are available. But I really wanted to focus on what exactly can AI potentially do, right? So I would divide them into three key areas. Number one, can we use AI to detect myopia? Because detecting myopia in large populations like in India and China is not such an easy task. And I'll show you, I'm sure some of you understand, and I'll show you why in a bit. And number two is, now can we identify individuals at risk of developing high myopia? As mentioned before, what we want to do is to try and prevent individuals from becoming highly myopic so that they have more complications. So can we predict who gets high myopia, who doesn't get high myopia? Not everybody gets high myopia. And last but not least, after we identify these individuals, how can we identify who to treat and how do they respond? Because we have so many myopia control options, how can we exactly see who to treat? And this is, I think, the areas in the future that AI can fulfill. So starting with detecting myopia. So here are a lot of publications that have been published recently in the last 2 or 3 years, detecting complications related to myopia on the right and detecting any myopia on the left in a variety of machine learning, deep learning, and other AI technologies. And targeting and identifying pathology is certainly important, as I mentioned before, being able to identify individuals with sight-threatening complications such as MMD, and we published a paper as well based on just retinal fundus images without using any OCTs. It performs just as well as clinicians, if not better, and we're able to use this technology to detect the presence of MMD or complications related to optic neuropathy, automatically using the AI as an assistive device. So this is something that's been replicated since then. So that was pretty old publication, maybe 2 years ago. In the world of AI, that's moving so quickly, that's old news. And now this has been replicated in larger data sets, and you can see that this is something potentially coming to fore. But the problem with performing AI for any kind of image-based deep learning is that myopic eyes are not regular eyes. Firstly, there are a lot of optical aberrations, so even a fundus photo can be difficult in a long eye with long axial length. OCTs can be challenging because you do need accurate segmentation and you do need to have large adjustments. And of course, in the highly myopic eyes, they can be irregular structures. But also, I think what's happening on a more optimistic note is that we are seeing huge advances in imaging technology. So this is OCT 3D reconstructed with wide field, and this is slowly becoming norm even in the commercial companies. So with the combinations of advances in imaging technology together with AI, I think this is something that we can potentially see come to our clinics a lot sooner. So as mentioned before, other than detecting them, we want to know who is at risk of developing either myopia or myopia-related complications. And again, we can see a huge number of research tools and research publications around this area. But I wanted to focus on myopia progression, because myopia progression is something that's very important. As mentioned before, we want to control myopia and prevent it from becoming highly myopic. So here's a really good study, which is machine learning based on large data sets from China. And basically what they're able to show is that if you're able to put together the data in terms of onset of refraction, risk factors such as age, as well as progression, you're able to detect which child gets more myopic, right? this is very intuitive because a younger child with highly myopic and coming in for 1 or 2 visits with progressive myopia obviously is going to be more highly myopic. So people question the use case of such a AI. For us, we went another route. We published this a couple of years ago, and this is based on deep learning. So what we did was we are able to use a single fundus image at baseline. So the kids are average about 6 to 12 years old. And based on that one single fundus image, we're able to use AI to detect which child progresses within the next 2, 3, 4, 5 years. So no repeated visit needed, one single fundus image, and we do not need to know the risk factors. In other words, we do not need to speak to the child, we do not need to know their age, we do not need to know gender, we do not need to know their refraction. So this is something that we believe will be the quality, the future of deep learning for AI detection and progression, and this again has been replicated across larger data sets in China and multiple countries. We are implementing this AI also on the ground. So what we want to know is, can we go to schools and communities to detect which child gets myopia, which child progresses, and of course, lugging a large fundus camera, and later we will see, I'm sure, other examples of how mobility is very important to implement AI. So we're using portable cameras to replicate and check, number one, are you getting good image quality, which is important to run the accuracy of your AI, but more importantly, is it accurate in detecting the AI progression or whatever I mentioned before, myopia progression, when compared to a gold standard large fundus camera. These are all promising, but of course we have to be aware that there are a lot of questions remain. As I mentioned before, fundus imaging is not routinely practiced in many myopia screening programs in East Asia, but is slowly becoming recognized as important. Should we be looking at refraction or axial length as an outcome? And how do we train these technicians to basically implement such infrastructure to enable the implementation of AI? And of course, as I mentioned before, after you have identified all these thousands of kids, let's say you're doing this in India, for example, and all these thousands of kids you've identified, what are you going to do with them? How are you going to manage these thousands of kids which you've told their parents that they're going to develop myopia over the next 1 or 2 years? So myopia control and treatment is the next step. And of course, you can't treat everyone. So you need to know who to treat. And in the last 5 years alone, fortunately, if those of you who are in the pediatric or myopic space will know that the number of myopia control options have expanded exponentially. This talk 10 years ago, we had like maybe 1 or 2 interventions, but now you can see, apart from our usual environmental, right, you have optical, of which I can't even finish putting out all the different proprietary designs. You have contact lenses, both multifocal RGPs, Auto K, as well as soft lenses. Low-dose atropine has been around for decades, so that remains one of the bedrocks of myopia treatment, and in recent years, light therapy. I've color-coded the various interventions or the classification. So you can see on the right, what we did was we looked at all the evidence based on randomized controlled trials or clinical trials, and then we look at the effect, the level of evidence, the effect, as well as the impact, both on the clinical outcome of myopia and also the cost of having such a treatment. So you can see in the last 10 years, as mentioned, in 2016 when we were at the academy, you can see the top is blue. Blue means pharmacological, which is atropine, and the number one evidence-based treatment was atropine, and you can see that the recent 10 years later, the number of new interventions that are rising in terms of controlling myopia are now rapidly being introduced into our market, and you can see now we now have a lot of other options available for our patients. But I just wanted to focus on one intervention, which is something which, as ophthalmologists, we probably prescribe the most, which is atropine. It's been around for decades. In fact, it's been around for 3 to 4 decades. And this is a study that we published, which is the first of its kind, looking at children who had atropine 10 to 20 years ago, part of our randomized trial conducted by our predecessors in SERI. And now they're all adults, and they're coming back to see me in the clinic. I won't bore you with the actual clinical results, but just to show you that this is the study design, and a lot of these adults are now in their 20s and 30s, and they had 2 years of atropine treatment. as part of the randomized trial. But what we wanted to look at is which adult now who has myopia now, who had treatment 10 to 20 years ago with atropine, who can we identify who were responders or non-responders, right? Because after you treat them in childhood, you have to wait 10 years to see their effect. And what we want to really develop, and what we've developed actually, is an AI that can be implemented in the practice. So what we have is now an AI where a child comes in, you can have a fundus photo, you have all your normal evaluation for myopia, and we can tell, okay, based on our AI, this child responds well to atropine, or this child doesn't respond well to low-dose atropine. And then the next algorithm would be, should I use a low dose or should I use a higher dose? So you can see the potential for AI is phenomenal, because you can now help the clinician advise the parents and decide on which treatment or which pathway to choose. And of course, we only have atropine now because atropine has been around for decades. The newer interventions, as mentioned before, have only been around for 2 years. So obviously this data needs to be collected, and it will be at least a couple of years before we can develop AIs for other kinds of interventions. So last but not least, I just wanted to share that, and this is common to perhaps all the other speakers in this session, of any AI session, is the challenges of implementation. All these stuff that I'm sharing are research tools. How can we actually show clinical value, the use case? How can we get all our hospitals and staff to use it and understand it? Do we have the hospital infrastructure, and who's going to pay for it, right? And of course, last but not least, security and ethics around using AI. So no time to talk about it, but back to remember what I said. All this AI cannot be implemented unless your hospital or your clinic has a myopia practice. So all our patients in the myopia center come in for their refraction, myopia assessment, and they all have biometry, OCTs, fundus imaging, and optic nerve assessment. Only when you have this, then you can put in your AI to implement into your ecosystem, and then you can then connect with the referral networks that you have in your country. In India, for example, you can refer to other hospitals or myopia centers or centers of excellence, from primary care setting all the way to tertiary care setting. So as you can see, AI is only one component that links it all, but all the components need to be there. But of course, the first step is to have the AI, and I think that in the near future, we will have an AI that can help us tell our parents and our patients who to refer for intervention, focus on high-risk individuals or high-risk children who are going to get complications or high myopia in the next 5 years ahead of time, and then who's going to get what treatment. And I think these AIs, if we can implement them and get good data from this, will really change myopia practice. So I'd like to acknowledge the AI team led by Dan in Seri, and of course my myopia imaging team, and I'm grateful for your kind attention. I overran by 10 minutes, if that's okay. So we do questions at the end?
Yeah, we'll leave the question to the end. Just a disclaimer, I did actually share with the speakers that they can actually have longer time, because we did have a few speaker short, and also it's also allowed the speakers here, is all the experts flying, like Travis, for example, flew all the way from US to share the expertise here. So don't worry about the 8 to 10 minutes. I'm going to break the rules today. So yeah, next up we have Travis. So he is going to share with us. He's going to take us to the cornea spin to talk to us about AI application for infectious keratitis. Travis, please.
All right, thanks so much. You guys hear me okay? Yeah. Thanks so much, Dan, and the organizers for inviting me to come speak. It's an honor. So again, I'm Travis Redd. I'm a cornea specialist at KCI Institute in Portland, Oregon, USA. So I'll talk a little bit, as Dan said, about using AI to differentiate microorganisms within infectious keratitis cases. I have no conflicts of interest. So, corneal blindness is fourth leading cause of blindness globally. The vast majority of those cases are caused by infectious keratitis. And, as we all know, infectious keratitis is characterized by microbial infiltration of the corneal stroma. It's pretty straightforward to diagnose a corneal ulcer. You can train pretty much anybody to see if there's a white spot on the cornea if the patient's in pain. The real management issue is determining what type of infection they have. So broadly speaking, there are categories of infection like bacterial pathogens, fungi, protozoa, and viruses. And that differentiation is really clinically relevant, because in order to eradicate the pathogen, you need targeted antimicrobial therapy that will actually kill that pathogen. And we know the sooner we get patients on the correct antimicrobial therapy, the better their outcomes will be. So how do we go about identifying the clinical pathogen? Again, this is the real challenge in managing patients with infectious keratitis. We can base our predictions on clinical impression. Myself and many others have looked at this quantitatively. I'm sorry to report that even us cornea specialists are really not very good at making this prediction. We're right about 2/3 to maybe 3/4 of the time at best. We can use cultures, which are generally considered probably the gold standard, usually have very high specificity, but very limited sensitivity, so we get a false negative result about half the time. And it also takes time to get those results. So while we're waiting for the pathogen to grow in culture, we don't know what treatment to start the patient on, and again, delays in treatment result in worse outcomes. We can use smears like potassium hydroxide, KOH, or gram stain. Those do require some specialized equipment and also some expertise to be able to interpret. I'll talk a little bit about that in a bit more detail. And then lastly, we can do biopsies of the cornea, but of course there's substantial morbidity associated with that and not practical for most patients with infectious keratitis. So it sort of begs the question, is there a role for AI here? Is there some way we could obtain more reliable point-of-care predictions as to what type of pathogen we're dealing with, and thus what empiric therapy might make the most sense? And so it turns out you can train, a variety of different AI models. Standard deep convolutional neural networks, sort of the most commonly used form of AI for computer vision, is actually quite good at making these predictions just based on photographs of the front part of the eye. So my group a few years ago published the study on the right here. The black line shows the performance of an ensemble of the deep convolutional neural networks, and the red line shows an ensemble of fellowship-trained cornea specialists. So short answer is here, if you take a large data set collated from multiple prior randomized clinical trials, you can train a convolutional neural network to do at least as well as cornea specialists at differentiating bacterial and fungal keratitis, which, as most of you know, are the two most common causes. Many other groups have performed similar studies. Dr. Soleimani in North Carolina published similar performance, also being able to detect acanthamoeba. Other groups have worked on detecting viral keratitis as well. So consistently across these studies in multiple regions, we can get models that perform, again, with performance that's at least as good as cornea specialists. But no one has really been able to move beyond this proof of concept phase. And I think there's a number of reasons for that, but probably chief among them is that the data sets that we're using are often not representative of the populations which we intend to implement these models in. So an example of this, the figure on the right here, again, is showing that study that I just mentioned. We train these models by collating data from multiple randomized clinical trials. So we, over the years, have collected more data from more randomized clinical trials, kept training models. We ended up with models that could get an area under the ROC curve of about 0.95, AUPRC of 0.98 when tested on those RCT data sets, which seems fantastic. But with the help of our colleagues at Aravind, especially Dr. Prajna, Dr. Lalitha, we were able to collect over the course of a full calendar year consecutive patients presenting with corneal ulcers, so prospectively collected, really representative data set of all comers with corneal ulcers, and that's what we call the MODER-I data set. So if you evaluate that model that was trained on randomized clinical trials, evaluate it on the representative data set, the performance plummets. So it doesn't generalize very well at all. Whereas if you train the model on the representative data, the MODER-I data set, it performs pretty well on its own internal test set, and it also generalizes to that RCT test set. So I think this just speaks to the importance of having, representative, ideally consecutively collected data when you're training and evaluating these models to make sure that they actually generalize to real-world populations. We also have this issue not only in infectious keratitis, but actually in medicine in general, that our ground truth is often very ambiguous. So as I mentioned, there is no perfect diagnostic test for infectious keratitis. And supervised learning, which is kind of the standard approach for most deep learning and machine learning applications, really requires that you have a reliable label or a reliable estimation of ground truth. And if you don't, if you have a lot of noise in the labels, that reduces the classification performance of these AI models, but maybe more importantly also affects their calibration. So you end up with models that are very overconfident even when they should be uncertain. And so my group has developed what we call latent supervision. There's a number of different ways to try and approach this problem, but essentially what we're trying to do is incorporate that uncertainty into the labels to train better calibrated models that can better handle this uncertainty. So this technique just uses actually a very old statistical modeling method called latent class analysis. Essentially, you can combine multiple tests, even if you don't have a gold standard, and estimate their sensitivity and specificity individually. And then you can use those estimates to come up with a Bayesian posterior probability of whatever outcome you're looking at, and then train the model directly on those probabilities. So again, essentially, to summarize, we're just trying to incorporate uncertainty into the labels to get more reliable models. And it turns out if you do this for infectious keratitis, it works quite well. If we use just the cultures as our labels, we can get decent predictions for bacterial keratitis, but not so much for fungal keratitis. If you use the smears to define your labels, it doesn't work very well for bacterial keratitis, but it does for fungal keratitis. Latent supervision performs quite well for both classes of keratitis, and these calibration curves show that these models are also better calibrated. So the closer this line is to the diagonal, the better calibrated your model is. So again, I think there are implications here for infectious keratitis, but also, again, this is an issue that we run into in medicine generally. And so I think similar approaches to this might help us kind of move toward models that can do better classification and do so with better calibration. We could also look at different types of inputs, right? So as opposed to just clinical photographs of the cornea, we could try to automate the smear interpretation process. This is an example of taking whole slide images of potassium hydroxide smears using a method called dual stream multiple instance learning, basically breaking it down into multiple patches, extracting the features from that using those CNNs, again, that I mentioned, and then using an aggregator that's based on a transformer architecture to make a final prediction. So essentially compressing these huge images of pathologic slides and coming up with a meaningful prediction based on those compressions. And it turns out if you do that, you can get pretty close to human performance. We also incorporated a diffusion model, which is a newer form of generative AI to enhance the resolution of those images. But again, you can get pretty close to even expert microbiology technician performance using methods like this. The other benefit is, I mentioned that aggregator is based on the transformer architecture, and because of that, it gives you these really nice attention scores, so a pretty meaningful heat map in terms of what the model's paying attention to, and that really helps with the explainability, which, as Dr. Ong mentioned, is one of the main barriers to implementing AI in medicine right now, is that often these models are sort of black boxes. So moving forward, I think AI shows a lot of promise for helping us take care of patients with infectious keratitis. I think really the three main areas that we need to focus on are improving the generalizability, the performance, and the accessibility of these models. In terms of generalizability, I think there's really no way to get around the importance of having representative and diverse training data for your models. There's a lot of barriers to sharing data between institutions. Approaches like federated learning might help us obviate some of those barriers. But I think we need to be a bit more collaborative to try and, again, get more representative data so that we can make models that actually provide benefit to patients. In terms of improving performance, as I mentioned, I think developing alternatives to supervised learning is one way to do that, either with latent supervision or other forms of weak supervision, potentially semi-supervised learning. But again, I would just emphasize that standard supervised learning often doesn't work very well for medical applications because, again, the ground truth is often ambiguous in these cases. And then lastly, improving accessibility is crucial to meaningful clinical implementation. So thinking about different types of input methods, not just clinical photographs, but also, again, maybe images of microbiology smears, OCT images, clinical history data, all these sorts of things likely would add additional predictive potential and, again, improve the accessibility of this technology. Too many people here to thank individually, but specifically want to thank my partners at Aravind Eye Hospital and my great colleagues in Thailand at Rajaviti and King Chulalongkorn, who were all instrumental in the work that I described. All the code for the algorithms and the projects that I mentioned is on GitHub. with the exception of latent supervision. That's not published yet. Within the next week, hopefully I'll have it up there, but I'm currently working on that. But feel free to access any of the code. It's all open source. And also feel free to shoot me an email if you have questions or interested in collaborating. All right, thanks so much.
Thanks, Travis. Very insightful talk. And next up, we have Anand Sivaraman. So he's going to talk to us about glaucoma AI in using retina photograph. Yeah.
Thanks, Daniel. I've sort of structured this into three parts. The first is in terms of the development of algorithms, and what we've realized is you've heard a lot in terms of the science that goes into developing algorithms. A lot of what we are going to also focus on as part of this presentation is what we call the implementation science. For example, in diabetic retinopathy, the algorithms that we and others have developed have been there for a long time, but it almost took us 6 years to actually bring it to actual use in public health settings. So we're going to be talking about some of those challenges even in case of the glaucoma AI algorithm that we're going to be talking about. Financial disclosures, have employment as well as stock within Remedy Innovative Solutions, but there is going to be generalizability for a lot of the results that you would see this for other portable fundus cameras other than us, as well as other AI algorithms that are available globally. And this is for the rest of the authors whose publications we are referencing in this particular presentation. I think to a lot of those in this room, these numbers are very clear in terms of the fact that 90% of glaucoma that's really undetected, leading to the 1.2 million, for example, in India, who actually suffer from preventable blindness due to glaucoma. The pooled global prevalence is anywhere from 2.5 to 5%. And of course, the problem statement is very clear that we don't really have a large number of glaucoma specialists who are going to be available for us to be able to bring them to the last mile for us to look at this as a public health problem. Now, the other challenge that we also have is across countries and across geographies, we don't have standardized guidelines when it comes to glaucoma screening, all the way from the US Preventive Services Task Force to what the World Glaucoma Society has indicated. And one of the things that has generally been concluded is there is indeed, even in the absence of global screening guidelines, there is value in high-risk population screenings, which can actually benefit from higher PPVs that we have. So in other words, unlike diabetic retinopathy, in order that even in the developing nations, we don't overburden the system, the specificity of these algorithms need to be very good. We really can't have very high sensitivity at the cost of specificity. So one of the things that we've actually looked at is to ask the question, why is it that it's very difficult to think in terms of last mile screening for glaucoma? It's just because of the fact that you don't have any single tool today that is available. And secondly, in the absence of that and without evidence to show that indeed the use of these tools will have a public health impact, it's very difficult to look at either a glaucoma screening strategy that's going to be universally applicable. Now, this is sort of being presented with some data here. If you look at all the way from RNFL thickness to this is the pooled sensitivity and specificity for each individual test that you would look at, all the way looking at tonometry to visual fields to looking at structural changes in OCT. What you see here is either there isn't a balance that you really need between sensitivity and specificity for you to bring this as tools to the last mile. And that's really is the challenge in glaucoma screening. So the question we asked ourselves is, can AI serve as a glaucoma screening solution that is adaptable to diverse populations? And some of what we are going to talk about now is essentially our work in that particular area. At Remedio, we have a portable fundus camera where we look at bringing offline on-the-edge AI algorithms. These run on the phone itself and do not require the images to be sent to the cloud. So the question we asked ourselves is it possible for us to only use retinal photographs as a modality? And is it possible for us to develop AI algorithms that are able to get integrated into a solution of this sort? And what could be the sensitivity and specificity compared to a complete workup that is normally going to be done by a glaucoma specialist? And where are we in terms of the risk of detection or not detecting someone that has glaucoma or referable glaucoma? And I think it was alluded to very well, even by Marcus and others. ground truth becomes extremely important, and kappa, in terms of getting multiple doctors to agree to stages of glaucoma, was a non-trivial aspect of a lot of this research as well. So what we do here is, starting off with ResNet algorithms, we have a quality check algorithm followed by segmentation, and an ensemble model that essentially classifies as either refer, no refer, either on the presence of certain changes that are seen as structural changes on the fundus images, where you would either look at either cup to disc, in which case it's a referral that is suggested, but otherwise if you happen to have RNFL changes, or if you happen to have neuroretinal rim thinning, all of these are used as ways by which you would look at urgent referrals in case of referable glaucoma, which is really the output of the model. And of course, in case where you do not have referable glaucoma, where even you don't have a disc suspect, then we look at a yearly follow-up, which is how the algorithm was trained and taught. So the aim of the research was to ask the question, can we assess the performance in prospective trials, not within the retrospective data sets that are used for training alone, but rather actual images being taken in the field in public health settings. These are, for example, nurse or ASHA workers who actually take pictures, that's on one side, to also vision center models like those with Arvind and LV Prasad, where we ask the question, can we actually pick up in vision centers using just retinal fundus images and this AI, the ability to actually have referable glaucoma being picked up. So two data sets. The first data sets that we use for validating, the first one is, of course, a Rotterdam IPAX AIOS data set that's available. This includes primarily different screening sites across the US and multiple camera systems that had central fundus images. The second is actually a pooled analysis from 3 clinical tertiary centers in India, namely Narayan Nethralaya, Arvind Eye Hospital, and LV Prasad. And the equipment that was used in the second data set, which is a prospective trial, is a portable fundus camera along with the Meteor's AI. We do believe that it may be generalizable to other cameras and other AI algorithms as well, so long as the testing is done in a prospective setting. So the methodology essentially involves 3 color fundus photographs being picked up to reduce the chance of ungradable images. Again, this is done non-mediatically without the need for dilation. The annotation is then done on the basis of whether there's referable or non-referable glaucoma, or if it's ungradable, and this is usually done by on a manner where if there is a disagreement between 2 glaucoma specialists, you ensure that you have a third that is actually stepping in order to be able to remove the disagreement. We had a total of around 112,732 eyes of close to 60,000 plus individuals from different screening sites across the US. And what was essentially done is to get the trial data set, use this data and actually get the original ground truth from this as part of the validation of the AI algorithm. What we then did was to essentially take, and in the first, one of the key things that we looked at is we did not look at just a portable camera alone, but we took images from all different types of cameras and asked the question, is the AI generalizable, the algorithm generalizable to all different cameras and across different ethnicities? The second data set actually involved data from 3 clinical tertiary centers in India, and the methodology was similar for all 3. There was the screening that was done, and the same patients were actually brought into a complete glaucoma workup, where there was a comprehensive eye examination and a glaucoma AI assessment that was actually done by a specialist. And that was common in all 3 centers, whether it was in case of LV Prasad or in case of Arvind Eye or Narayan Nethralaya. So the sizes of the samples in the 3 centers were as you can see below, and these were published in Nature Eye and in Ophthalmology Glaucoma, the results of this. And what we essentially did in these 3 studies was essentially use an undilated image from the portable fundus camera along with the use of the Meteor's AI for looking at glaucoma. And the grading protocol essentially involved the specialists actually having from the same patients the OCT, the visual fields, as well as direct clinical examination, along with the ability for them to actually have pressures and other workups that you would normally have as part of a glaucoma, comprehensive glaucoma analysis. And these were the results. This is the results that we have from the study in Europe and the US. The US data basically shows a sensitivity of around 90.96% and a specificity of around 92%. And what we look from an explainability perspective is to also ask the question whether or not you have the class activation maps actually indicating the same structural changes that you would otherwise have glaucoma specialists already look at. And what was also interesting is the fact that it was reasonably similar to what we also saw in the prospective studies that were done in India. We're using the same AI algorithm, but in this case, using the portable fundus camera with the retinal images being clicked using the portable camera. So this is essentially what was done in these were the results of the prospective trials that were done in India in the 3 centers. Now, what's actually very interesting is we then looked at the true positives, and we wanted to essentially look at what are we missing? Yes, it's 90% sensitive, but what are the 10% that we're missing? We realized that in most cases it was early glaucoma that we would miss, because those structural changes can sometimes be seen better both functionally as well as in case of OCT, which is really what we saw. But otherwise, you could see the fact that the AI was picking up changes that you would otherwise look for a glaucoma specialist to look at either in an OCT. But interestingly, it was actually picking those up as very minor changes that were being seen on the color fundus images. So the correlation between what was seen on the fundus images versus what was seen on the OCT versus what we would see in terms of the mean deviation, the PSDs on the visual fields, was something very interesting to observe. And so what was if you now go back to the first plot and you ask the question, where does this stand in terms of the AI algorithm, in terms of the pool sensitivity and specificity? It's interesting to sort of see that there is the promise, therefore, of the use of this AI for us to be able to look at a low false positive rate while having a reasonably high sensitivity for detection of those with referable glaucoma. Now, that's the part on the validation. Sorry if this is not showing up very well, but now what we are starting to do is starting to collect data from all the devices that have been placed across India using AI, and we are starting to see what's the actual prevalence rate and how is this comparing with studies that have been actually published in literature from tertiary centers. So here, all of these cameras are actually being used in public health centers. They are being used in public health centers in Kerala, in vision centers in Arvind and LV Prasad. And what's interesting is, right now the data from Tamil Nadu, Karnataka and Delhi or Telangana, around those 3 or 4 places indicate very clearly that you're between 2 to 4%. But interestingly, there are certain places where the numbers are actually higher. So now we have to go back. It could be that we have to go in and look at whether or not this is due to the quality of data or whether it has to do with the protocols that are used. That's where we are now working with the Glaucoma Society of India and with researchers in India to now look at guidelines by which we could actually bring this to scale across India and then globally. But that's a lot of what we've done so far as well. And what this also allows us to do is start looking at data across India in terms of what's the percentage of those that we're picking up from fundus camera images, those having cases of referable DR and referable glaucoma. And it's very interesting for us to see those numbers and how they compare in a community. So for the first time in India, you're able to actually get epidemiology data across different centers in public health centers as well. So in summary, the training was shown to be robust with the approach of actually not going for a large quantity of images for training, but reducing the quantity of images, but actually having a lot more of the ground truth that actually is very important for agreements on. The offline tools are a way by which we can actually bring these algorithms to the last mile, and that's been seen where around 2 weeks back, the government of Kerala has become the first province globally where AI-based screening for 3 diseases, diabetic retinopathy, glaucoma, and AMD, is now being done in family health centers, in 210 family health centers. Of course, that's only half the job done. As part of the implementation science, we continue to monitor to see utilization as well as whether there are any spurious referrals that actually step up. And real-world implementation data today is therefore promising if you want to screen at-risk populations. So lots of people to thank, especially those from the Arvind Eye Care System, LV Prasad, as well as Narayan Nethralaya. But happy to take questions. A lot of the focus was on the validation, but more importantly, there's a lot that went on the implementation science, where thanks to all of the doctors, because it's not easy to actually do many of these studies, especially in case of glaucoma, where you need to bring them back for a comprehensive workup. Unlike the case of diabetic retinopathy, where you have a certain standardization of just the fundus images being sufficient for grading. So thank you so much, and happy to take any questions.
Thanks, Anand. Yeah, well, maybe we keep the questions for later. Yeah, so maybe answer this quickly, and then, yeah.
So So the ones with the study have been done primarily in tertiary centers in Narayana Nethralaya, LV Prasad and Arvind. Thereafter now it's in the vision centers of Arvindai as well as LV Prasad and in family health centers, also called public health centers, which are where ASHA workers primarily look at those who come in more than 40 years of age or at risk as a result of a genetic basis. Yeah, in some. So right now, since the guidelines are not there, we can't assure that it's the same everywhere. And that's the reason why we now have to standardize how the screening is done. Correct.
Yeah, thanks, Anand. Can we get the next presentation up, please? We have Racing Wang presentation.
Hello, everyone. Thank you for being here today.
Thank you.
I'm Racing Wang. As we all know, strabismus is a common eye condition in children with an incidence rate of 4%. It can manifest at any stage of visual development and may lead to lifelong eye misalignment. The early screening and consistent follow-up are essential. However, current healthcare model for strabismus heavily relies on hospitals due to the prevailing screening method of manual prism and cover test. This method faces challenges such as high label costs. Several studies have developed automatic methods for strabismus measurement. The classification-based method, which uses simple RGB images as input and employs deep learning algorithms to determine the presence of strabismus, falls short in achieving high precision quantification. The regression methods, which calculate eye position based on corneal reflections in images, requires the use of infrared cameras and additional hardware. Therefore, based on our previous work of digital modeling and disease screening using ocular appearance imaging, we aim to further develop a smartphone-based technology for precise and automated strabismus measurement. Here, we propose a digital ruler of strabismus, which uses 30-second cover test videos as input to automatically measure the deviation of strabismus, classify different types of strabismus, and dynamically evaluate intermittent extropia over time. This is a demo video visualizing the measurement process of digital ruler by performing a 3D reconstruction of the alternative cover test.
Place the phone in front of the patient as shown, and instruct the patient to stare at the sighting target. The examiner can move the occluder based on the audio prompts. Cover one eye. Uncover. Switch and cover. Uncover. Switch and cover. Switch. 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 One more switch. Uncover and done.
We conducted a prospective multi-center clinical study to compare the diagnostic performance of digital ruler with the manual prism alternative carting cover test according to expert labels. A total of 335 participants and 459 videos from 3 ophthalmic centers were included, with a median age of 10 years old, ranging from 3 to 72 years. First, we compare the diagnostic performance between DRS with the manual one for deviation measurement of horizontal strabismus. There is a strong correlation between DRS and manual PACT for deviation measurement of horizontal strabismus, with the mean differences of 1.06 PD. For vertical strabismus, there is also a significant correlation between DRS and PACT, with the mean differences of 0.35 PD. Subgroup analysis were conducted to evaluate the diagnostic performance of digital ruler under different conditions, including differences in strabismus type, data source, measurement distance, and whether the glasses are worn. Second, we evaluated the performance of digital ruler in strabismus classification. We performed 3 types of classification. The first, whether strabismus is present with a high sensitivity of 0.97 and a specificity of 0.93. Second, we further classified different types of strabismus, including differentiation between phoria and tropia, and extropia and esotropia. Finally, for intermittent strabismus, digital ruler can dynamically reconstruct the realignment time and speed during the examination, offering novel methods for observing and measuring the disease dynamics. In addition to comparing the performance of DRS with the manual PACT, we also compare it with current automated methods, including the appearance-based methods and other reported ones. We can see the digital ruler performed better than the 2D method and showed better performance than the reported studies that using smartphones for strabismus detection. And this also showed comparable performance than other reported studies that using additional devices on the vision measurement. Additionally, compared to other reported studies, our research can also provide dynamic evaluation of intermittent strabismus. Overall, the digital ruler is a precise, reliable, and patient-friendly tool for strabismus measurement and diagnosis. Thank you.
Okay, thanks. So I think maybe we open the floor for discussion now. Any questions about, please speak onto the mic and we'll get the speakers to address the question. Thank you.
This is regarding the corneal AI. Do you have the comparison of PCR with the predictability of your photograph, the AI-based module? The predictability in relation comparison with the PCR done on the same patients.
Yeah, great question. So for viral keratitis, we have a lot of the PCR results. As you know, the main downside of PCR is that you have to have a specific primer to the pathogen that you're looking for, right? So yeah, we routinely get HSV and VZV PCR, acanthamoeba sometimes as well, but there's not too many other pathogens that we get PCR for. I think as many of you probably know, there are newer hypothesis-free molecular diagnostic methods like metagenomic deep sequencing, for example, that I'm hoping over the next few years will let us get more accurate diagnostic information from molecular tests. But
your module, does it help us to find out whether the patient is regressing or progressing with the treatment?
Yeah, great question. So the current models that we have trained don't do that. We don't really have the longitudinal data to get accurate measurements of both progression over time, and what I'm really interested in is, I think what you're alluding to is response to treatment. We're hoping to do studies along those lines. There's been, you may have heard some issues with funding for medical research in the US over the last few months, so we are actually planning to propose that study, and it's on hold for right now, but hoping in the near future we'll be able to do that kind of work.
Thank you.
Thank you.
Travis, you can consider Singapore if the US funding is getting cut. Okay, anyway, just follow-up questions. Maybe like on the AI algorithms that you had, you know, like for layman retina surgeons who don't understand, like, you know, cornea that much, But I think one of the things that we wanted to know is that whether this patient can we start steroids quickly, right? I mean, whether there's a fungal versus not, right? So I'm not sure whether in the pipeline of the thing that you guys are thinking about, is there one of the things that should be included in the algorithm?
Yeah, definitely. So I think there's been a fair amount of work trying to determine the role of steroids in different types of infectious keratitis. It's pretty well established, sort of, which pathogens you might consider steroids for. So I think it sort of follows from, determining the type of pathogen then helps you inform like whether or not steroids would have a role. But I think I mentioned at the end of my talk that, moving forward, I think more multimodal machine learning, incorporating clinical history, treatment history, things like that, and then monitoring over time, I think is going to be really crucial to enable us to do those sorts of predictions.
Yep. Thanks, Travis. Yep. Question?
Good morning. May I ask one question based on AI, sir, on AI-based imaging for glaucoma? Are there any specific parameters that we see with the AI, like you mentioned about vertical cup disc ratio, if I'm right, and segmentation? So is anything else more to parameters which are like specific for the AI imaging, sir, that we are looking at?
The way we've actually done this is in a manner where the AI learns, and we see that in fact it's not just the VCDR, it actually looks for changes in the optic nerve head beyond that. So you're really looking at neuroretinal rim thinning, RNFL defects, other changes that are there. VCDR is just one of those, but these are the others that it actually gets trained and learned on across multiple modalities of data. So it's fundus images as well as all other data from the ground truth.
So, but one thing is, even clinically, these things, even RNFL defect and thinning also can be found. So what does AI do that's more precise that I like to know? And about the heat maps, you mentioned about heat. What is this thing about these heat maps?
So there are two things here. One is the intent of the algorithms was to ask the question, if we use this along with fundus cameras where there are no doctors, where there are no specialists. That's the intent of how it was developed primarily for that. The second is if you're looking at other questions such as progression or other questions in terms of one of the things that we know in LV Prasad that was done as a study is looking at the same algorithm being used to identify those that are in mild versus moderate versus severe. There it was very interesting where it's anecdotal evidence, but we still have to do a clinical and a scientific study to establish this. But oftentimes some of those changes in the fundus images are not very easy to pick up. So they can be missed very easily, unlike let's say in an OCT where there's automation that allows you to actually pick those up. So in those centers like in general ophthalmology where you may not necessarily have higher modalities, we think that there could be a lot of relevance for such algorithms where you're able to essentially move the patient into a care pathway to a specialist as a result of being able to do on a fundus image, be able to pick up some of these changes that are otherwise not very easy compared to just doing a pressure check and a 90D.
Thank you, sir.
Yeah, this also, I also would like to add to the glaucoma diagnosis in the early stages, We know that the GCC always precedes the RNFL lesion, RNFL diagnostic values, so. But the recent high definition OCT analysis comes to our help in some cases because the segmental analysis, so that is possible that certain type of glaucomas have a certain type of segments involved.
Mm-hmm.
So there is an AI algorithm for that. So what about that? Can we use it for the early diagnosis of glaucoma when other features doesn't help us to diagnose glaucoma? That's one question.
I'll possibly open this out also to ophthalmologists on the panel, but at least in what we've seen is to a large extent, if you're looking at other modalities like OCT, and if your question is it possible for us to use AI to pick up early changes that are seen in high resolution OCTs? I think detection, or speaking purely from the science of AI development, there's innumerable cases of everyone being able to show that if trained well, it is able to do a very good job of picking up and detecting. The clinical relevance of it would be something in terms of what does it indicate in terms of management would be actually very important in defining what the AI should do. Otherwise, I think it's been reasonably well established that AI does a fairly good job in being able to detect especially structural changes if the resolution and the ground truth is available.
Another aspect about the cornea, so the corneal ulcers and the role of AI helping us to diagnose the difficult cases. So most of the time, it is, we know that we are able to diagnose the type of infection from the morphological appearance, the external appearance. But there are many a time when we are not able to, there doesn't have a confirmed to any accepted type of infection, say for the viral, the fungal, or the bacterial, or anything else, So, is there any AI mechanism or an AI algorithm when in such situations, when if you use that algorithm, the AI diagnosis that this is this particular type of organism causes this infection?
You mean in those cases that are ambiguous in terms of the morphology of the ulcer, you're having a difficult time determining if it's bacterial or fungal? Is that what you're asking?
So I think
sorry.
volume.
Sorry. I think, so you're asking about those cases where it's ambiguous, right, whether it's bacterial or fungal based on the morphology. You're wondering if an AI algorithm would help differentiate those?
Yeah.
Is that, am I understanding correctly? Okay, yeah. So I think to an extent, yes. As I mentioned, there's been quite a few groups looking at this question from multiple different areas, and I think the performance has been pretty consistent across those studies that, images, particularly clinical photographs of the cornea, probably contain enough information to differentiate specifically bacterial and fungal keratitis with somewhere around 85% accuracy. So it's not 100%. There's always going to be some information that's not contained in the morphology of the ulcer, but there's enough to make a substantial prediction. But again, to kind of harp on this multimodal issue, I think we need to incorporate other information sources to really push that accuracy higher.
Maybe I can also direct the questions to Marcus, right? Being a corneal refractive surgeon as well. What do you see, like how, the cornea specialist should use an algorithm that what Travis has just, described? I know, like Marcus is, presented the myopia AI, but in his day job, he's a corneal refractive, the head of corneal refractive in SNAC. Well, what do you think?
So I think the challenge, I think Travis probably highlighted this earlier. I think the challenge for cornea, AI in cornea in general, as opposed to AI in glaucoma and in retina and in myopia, is the imaging. We've been pushing very hard to have a unified, at least among cornea specialists, to have a unified way of the way we image. So for example, in my center, the way we capture our slit lamp images for even cornea ulcers varies between technicians. A retina fundus photo is always the same. It's centered, same size, same MAC, centered on the disc. So as you know, AI, so that's the first problem. So the AI needs to train on a standardized photograph or image, and we don't have that in cornea. So that means that morphology, right, requires, or studies of morphology and training the AI requires some form of adjustment in terms of magnification, etc., etc. So color, etc., etc. So you can see a big problem here. So I think number one, that's what we need to do. And then number two is, when are we going to use it? So I think, for example, what's been highlighted across here is, crucial diagnosis, or diagnosis where microbiological specimen and PCR or culture takes a long time. So like fungal, for example, or atypical keratitis, right? If you are able to train, even though it's not common, but because the diagnosis is crucial to clinch at an early stage, I think that's going to be a very powerful use case. If you tell somebody, oh, I can diagnose Pseudomonas, I mean, if it's, as long as it's not resistant, I think most of us can treat it. So I think, but identifying atypical keratitis early would be a game changer as well. I mean, this is my 2 cents worth for AI in cornea, at least for infectious keratitis. Sorry?
Like in retina, they have a deep learning system which differentiate whether it is a dyschedema, papilledema, or other causes.
Exactly. So just to repeat what I said, just
like in retina, there have been studies like these, bonsai studies, probably you might know. It could differentiate difficult cases of a discedema, whether it is papilledema or is it something else, with accurate, with good specificity and localization.
Yeah.
Likewise, can we have a program with deep learning with many of these pictures, morphological pictures being fed into millions of such pictures? So that could probably identify this one is due to a virus infection or a bacterial infection or otherwise.
Yeah.
Is there is there a possibility, or are there any studies going on that?
Yeah. So I think back to what I said, for the retina guys and the glaucoma guys, the image are always standardized, and even the OCTs are standardized. So when you do an OCT macula, it's always the same 3x3, 6x6, 12x12. But when you order an OCT of the cornea, there's no registration. So with an infectious carrier, even if he said, okay, I want to verify this with multimodal imaging and add in a tomography. You have tomography from company A, tomography from company B, 3x3, 6x6, over the ulcer, and then sometimes over the limbus. And so that's the problem. You can't train an AI when you don't have a standardized photo and you don't have a standardized imaging modality. I think that's the biggest barrier. So I think as a society, and we brought this up at various platforms across supranational cornea societies, it's something that we need to start doing. I mean, it's never too late. If we can have a standardized way, and retina people did it, glaucoma people did it. So if we want to build AIs for cornea, we need to start there and then start building the AIs.
Yep. Yeah. Next question. Yeah. Oh, sorry. Yeah, Travis.
Sorry. I couldn't agree more with everything that Marcus said. I did show one quick slide that just showed that our model that was trained on multiple, an amalgamation of multiple RCTs didn't generalize very well. And I think that gets to exactly Dr. Ong's point that if you're using a different imaging device or different imaging methodologies at different sites, and different sites have more or less bacterial or fungal keratitis, the model is going to pick up on those subtle differences and essentially result in label leakage. So without that standardization and without large-scale, geographically diverse data, we're not going to be able to make progress on these issues.
And here comes an opportunity for a company like Remedial, for example. So if Remedial goes out and invests money, and you go out into India and you tell everybody to use your device to take that cornea photo in exactly the same way, the same magnification, right, on all your ulcers, you're going to be the leader in this. Because there's nobody else who's doing it, right? So I'm just using a deficiency as an opportunity for a company like Remedial.
Yeah, there you go. Opportunity for Anand to consider. Okay, next question. Yeah.
Right. Great presentation and a lot of insights. I have 3 questions. I'll be very... Yeah, so great presentation and a lot of insights. So I have 3 questions. One is, in terms of screening software, screening solutions, do you require a specialized device or smartphones are there? You can do that. That's number 1.
Actually, maybe we start with the first questions. Panel. Anand? Yep.
So this one here is not just smartphones. It's a smartphone-based fundus camera that's validated to perform as well as traditional desktop systems. So any devices that meet that criteria is what the extension of the results could be to.
Right. And the second question would be in terms of the AI algorithms. I just heard this multimodal things. Is there a promise that if you use various things like OCT, fundus image, maybe some other things, would it perform better?
So always the way we look at AI at the end of the day is the technology. I think it's more important on the problem definition and what we are trying to solve rather than the technology. So one of the things that we asked ourselves is it's not going to be possible today, maybe in the future, but not today for us to get portable OCTs at scale. Whereas fundus imaging devices are reducing in cost significantly over time, and it's not us alone. There are many commercial players that have done it. So the constraint therefore we pose to ourselves is to say, if we have only one modality, how do we actually detect those that have risk? That's how we frame the problem from technology development perspective. Yes, to your question in terms of will it improve in performance, yes, more data is good, but what our learning from the entire glaucoma algorithm development has been is quality is actually more important than quantity of data, especially quality of ground truth in those cases where you have divergence in ground truth especially. So yes, it is possible if the problem is defined as something that you want to pick up from within. If your question is response to therapy, then it's a very different way by which you develop the algorithm.
Charis, Marcus, any other additional point? Both you guys also shared about your multimodal, both in cornea and myopia. Yeah.
Yeah, I think I actually wouldn't add too much to what Anand said. I think he's spot on that, you know, it really is a matter of starting with the specific use case or what application you're trying to envision, and then working backward from there to see what's feasible and what's going to accomplish that goal. So yes, you know, additional imaging modalities will almost always add additional information, and most modern deep learning models are able to, you know, meaningfully use that information. But you know, it starts with the practical considerations of what's actually going to be implementable at scale to provide some clinical benefit. And then, you know, I think it's not just a question of multimodal inputs, but also thinking about the labels, so, or multimodal outputs, or, you know, using multiple labeling sources. That's sort of what weak supervision is, to try and get as close to the ground truth as possible. And if you can't get close to the ground truth, to at least be able to quantify how much uncertainty you have about the ground truth, again, to, you know, result in hopefully models that are less overconfident and better calibrated.
Right, and you know, in terms of, is there scope of like these foundational models, right, where there's a less need of label data, like red found? Is there a promise there that that would be, you know, that would be one of the leading solutions? And the last question is to Dr. Anand. You know, your solutions, what was the typical size of the images? Was it in terms of lakhs, crores, millions? I mean, how big was the data set? You know, for
So the size of the data set itself was actually not very large. In case of us and others in DR have shown that 60,000 to a lakh, but in glaucoma we used far lesser images, and that's where the bigger challenge for us in glaucoma was actually the kappa among ophthalmologists, the ground truth, and that was more important. So more and more, especially with multimodality data, quality becomes more important than quantity is really what we have. So the number of images was far fewer. It was tens of thousands, but not more than that. So foundational models, it's early. We are into it, but at the end of the day, it comes once again from the problem statement that you're trying to define. There is the chance of specificity loss that comes in, but more and more, for example, today we are asked by the government to say that can you look at eye as part of non-communicable disease screening? So why do you have to just look at, can you look at abnormal and normal, as opposed to saying glaucoma versus DR versus others? Interesting problem statements, but they also have challenges of specificity loss, especially when you look at foundational models, but maybe others in the panel would be able to answer that better than me there.
Yeah, maybe I can just add a few cents of thoughts. I think going back to the question 2, multimodal versus a usability usually is a good balance. So if you take a poll in the audience in a room, which is all practicing ophthalmologists here, you need to first ask them what would be the imaging modality that it makes sense for you in your routine clinical practice to actually, you know, screen your patients for or diagnose your patient for. And most of the time they say less is more. If I can use one device to actually do my job, I'll do it, because, you know, in India, you guys will be flooded with so many patients here. And how do you have time to actually do like 3 or 4 different modalities to give you that kind of, you know? So I think sometimes it's a balance between too much versus too little. I think that's the point that I wanted to make. The second thing about foundation model is it has really shown a huge promising in the computer science world. And the reasons being is that the images have ability to learn without being explicitly taught, right? So you start seeing words like self-supervised, unsupervised. And we know, compared to the previously pre-trained model using convolutional neural net, using the image nets, cats, the dogs, the elephants, the rate found model that you just said has actually demonstrated that if you use imaging-based specific data sets to train a foundation model, it actually increases your training accuracy by at least 5 to 10% or more. So again, this is a rapidly evolving field that a lot of the people around the world is currently looking at. So if the team has the technical capability to build foundation models, I'll strongly advise to, but of course, it's always limited by the ability of you accessing the GPUs, the supercomputers. That's always a limiting factor, yeah. So I think those are the 2 points for you to consider, yeah. Next question, yeah.
Thank you. Very nice presentation. My question is not on AI. I just wanted to ask Dr. Marcus, can you please tell us a little more about red light therapy? It's not common here. Thank you.
So thanks. So red light therapy is something that's come to fore only in the last couple of years. How it works, actually it was developed by accident. So it was first developed to treat amblyopia. And when they treated the amblyopic eye in children, they found that the axial length started shortening. Yeah, so it is the only therapy based on randomized clinical trials that suggests that you can reverse axial length elongation. So from that, it became very exciting. It was commercialized, and there are variants of that, both approved and non-approved, mainly in China at the moment. Unfortunately, the CFDA pulled back 6 months ago because it was not regulated. So it was a home-based therapy which people could buy off, optometrists or eye care specialists and bring home. And then there were some reports of retinal and macular toxicity because you're essentially doing intermittent red light shining. So for example, one of the therapies is 3 minutes twice a day, and the kids have to wear like a goggle, and they shine a very certain dosage of red light wavelength into the eye, and you literally have to stare into it. And I've tried it, and literally when you take it off, you still have that red, like watching a screen for a long time. So you literally have a glow that's persistent. Yeah, like looking into the sun, basically. And so because of those reports of toxicity, almost like a solar retinopathy, they pulled back. But it is still a very promising technology. If it's regulated, if the quality control is good, I think that it will rapidly become part of myopia control, only because it has shown axial shortening for the first time, yes. Nobody knows how it works. Just like how atropine, nobody knows how atropine works actually. Okay, so the companies are, everyone's different. Yeah. But this red light is red light.
I wanted to ask you, supposing we put on a red night light when children are sleeping diffusely in the room, do you think?
Doesn't work.
Okay.
Doesn't work. So a lot of the wavelength-based ambient light therapies based on clinical trials haven't been very successful. Probably before red light, there was a violet light like glass that you wear, and that shines like spectacles that shines a violet light. Even that sort of like.
Just a last comment, this red light which you're saying, they are pimple patches which teenagers wear for acne. These little red lights, you're supposed to put them on for 6 hours. So I was wondering whether we can, when I heard. Thank you so much.
Thank you, panel. It was a lovely discussion, lot of insights. I have a question for the doctor who presented on myopia and AI. Did I hear you right when you said that from a single color photograph, there is a study where myopia can be predicted, so without any serial photographs taken? So can you just throw a little more light about that? Like what were the parameters that were considered?
I don't know. I just gave the photos to Daniel and he did it. No. We published this in Nature Digital. So what I said was, it's been published a couple of years ago, and we're obviously, as I mentioned, implementing this in our prospective study. The idea came from the use case. We wanted to get around the unmet needs of myopia screening and myopia detection. Right now, to detect myopia in Singapore or in high prevalence countries, you have to do visual acuity, you have to do cycloplegic refraction. It takes 3 hours. You can add an axial length. You want to know the risk factors, so you got to speak to the child, the parent. You need to know the myopia diary. It's impossible. So what we wanted to do is, we had the hypothesis. We just use deep learning, right? And even that algorithm is a bit outdated now. But anyway, it's a deep learning approach. And from the fundus image, one baseline fundus image, we're able to predict myopia now and in the future, up to 5 years. Yeah. And just to touch on what our panelists have been saying, the credit of this result, this study, is not on me. It's on our seniors and our predecessors. It was based on a data set that was collected 10 years ago. And what's important, I feel, the reason why our AUCs are so high is phenotyping. So the phenotype unlike glaucoma, myopia is a very objective outcome. It can be measured objectively, and we do it very rigidly. So proper cycloplegic refraction, proper cycloplegia, which takes hours. So all our clinical trial subjects and our children, 10 years ago and even till today, go through a very rigorous phenotyping. And if you have a very strong phenotype, then your AUCs come out very high. When you have a subjective outcome, like whether you have fungal or not, is based on whether somebody thinks it's fungal or whether somebody thinks it's glaucoma, then you're going to have AUCs that fluctuate a lot. The other thing is that when you have tight phenotyping, you can replicate it. So for example, because our phenotype is tight, when we use the AI in another data set from China and in Vietnam, the AUCs are still very good because your phenotype is tight. So these are all the principles of AI, I think, and you'll see this theme coming up again and again.
Thank you for that. My next question is for Dr. Anand, and a bit of it is already answered by David. Though as a technologist, your aim is probably to give the last mile coverage, with a frugal device like a fundus camera. As a clinician, my concerns are, what are the collateral benefits that I have for me as well as my patients? So like how Dr. Marcus said, how am I going to make my diagnosis of glaucoma more accurate with the least number of instruments? The screening more accurate, the diagnosis less ambiguous and more accurate, and how do I proceed? Now, right now, I would need at least 4 to 5 devices to arrive and go forward with my management of glaucoma. Are we saying that, just by having Meteor's AI, I will not be needing some other instruments? Are we getting there, or are we already there? Can you claim that?
Okay, at the risk of, first up, I don't think we can claim that just yet again. Again, there's also, when you look at a prevalence, when you look at something like glaucoma at a population level, right, the risk to benefit is very different compared to what you do within a clinic. Let's, for example, when we do a clinical study today purely from the perspective of performance, if you were to look at standard of care in the outreach, the standard of care is no care, right? Versus when you look at standard of care within a clinic, it's very different. So to answer your question, I think the future definitely is there. I'm going to go on a limb saying that there is going to be a reduction in the number of indications that are needed. And I don't think that's as a result of the fact that we ended up overdoing a lot, but it's just the fact that there's a lot of data that I think ophthalmologists have from different devices. So either two things are going to happen. There's going to be first standardization that has to happen. I don't think we need to look at things reducing. I think we're going to look at a period where reports, interpretations, all of these are first going to get standardized. I think we need standardization of workflows, standardization of inputs, as well as standardizations of outcomes. And only after we go through that phase, I do believe that there may be the promise of actually reducing modalities, so long as, once again, the question being asked is relevant for that reduction. So it's not generalizable, and at least a little that we've looked at so far.
At this point of time. So while we were doing the DR,
sorry, our sessions is ending already. We need to just keep it short so that the other next speakers after the session, please feel free to reach out to the panel. Yeah. 1 minute.
Thanks for letting me. Yes, just 1 minute. In DR, we had two limitations: the pupil size and media opacities because of cataract. So here with visual fields, again, I have a similar problem. So how is it that, have you looked at these two parameters? And even corneal thickness, since you have one more device which also measures pachymetry and also fundus image. So have you done anything so that we can eliminate the pachymeter out of my, the budget of things that I should acquire?
Sure. I understand the problem statement. I think the way we've looked at it so far is purely as a detection problem. And what we would need to do really is, even with the retrospective data that you may have, there are ways by which you could have algorithms that are developed by which you take each one out and see what the impact of it is. It's almost similar to PCA analysis or principal component analysis or sensitivity analysis that's normally done. So I think the research can guide us there. I have not gone enough into literature at this time for me to be able to take a stand and say that we are at a point where we can eliminate modalities. But I think there's enough data, and it all comes back again to the data and the way the data is organized for this. It's a solvable problem in terms of using AI for us to be able to answer the question, can we reduce the modalities? if the data is available, we can actually do this fairly quickly to answer that question. Do we know that yet? I'm not sure.
Okay, thanks guys. I need to close this unfortunately, but keep the question flowing to the panel and then do come up. So with this, thanks guys for attending the sessions. Thank you, the speakers. Yeah, thank you.